topic on Gallstone Disease, a strategic approach in our daily practice. So I'm currently the medical director of the Gall Clinic in Mount Elizabeth Hospital. I've been working in the university for more than 10 years. That's why now I'm still the adjunct professor in the university in Singapore. Some of the papers I'm quoting, some of the publications I made when I was still working actively in the university. Well, without further ado, I want to talk about this very common topic on gallstones. I think everybody will see gallstones, right, in our clinical practice, and it's something that we want to see whether there's anything new, any concept new that we can think about. I remember when I was a medical student, and after that when I was a resident, I was always told this common phrase of "don't trouble unless trouble troubles you." That's regards to gallstone. You know, a lot of time my teacher will say, "You got gallstone, but it's not causing any trouble, so don't go and take it out. Don't trouble unless trouble troubles you." Right? You heard about this? So let's see, what trouble can gallstone produce? First of all, the gallstone can obstruct the cystic duct, right? So when it obstructs the cystic duct, then it can cause all these symptoms like biliary colic, cholecystitis, empyema, mucocele. Yeah. Subsequently, if the stone migrates out of the gallbladder into the bowel duct, then it can cause cholecystolithiasis, cholangitis, and so on and so forth. And further down, if it obstructs the pancreatic duct or it injures the pancreatic duct at the ampulla, then it can cause pancreatitis. And finally, if the gallstone has been there for some time, we know it's associated with gallbladder cancer, like in this particular patient. But we do know now that there are two main types of stones. Okay? The first type is the cholesterol stones, and the second type is the more common pigment stones in our region. Just now we mentioned about the complications of gallstone, and a lot of them they occur when the stone starts to move in the gallbladder, right? When the gallstone starts to move in the gallbladder. So do these two types of stones have different mobility characteristics? So some time ago when I was still in the university, I studied the gallstones among our local population, that means Southeast Asia, in our Asia population. And I found in this large number study of 530 patients that majority of our patients are pigmented stones. Whereas in the American or the British textbook, of a lot of time, what they publish in regards to cholesterol stones. So our local stones are quite different from the stones that's being described in the textbooks. So in the textbooks, we say, okay, don't trouble unless troubles you. Maybe they are related to the cholesterol stones. And we can see just now in our picture, in the earlier picture, these types of stones, the cholesterol stones, the bright yellow, so-called cholesterol polyps, a lot of time when we do the surgery, the stones are stuck to the gallbladder. They are not mobile. Whereas the stones in our local population, in Indonesia and in Singapore, we have the pigmented stones. They are very mobile. And there, maybe they'll behave differently. Okay? Take for example, there's this particular patient that I recently have. Okay, when you question the patient, she says, I'm not symptomatic. I don't even have the dyspepsia. Yeah, sometimes we told the patient, tell us they have this symptom called MA, right? Very common. But in this particular patient, she said don't, but she's diabetic. Okay, no symptom. But you look at the gallbladder, there are some stones, and you quickly can see the gallbladder wall is quite contracted despite being fasted, and the wall is a bit thickened, and you can see within it there are some stones. And if you do a simple test during the ultrasound, you move the patient's position, and you study the gallstone, you find that the gallstones are moving. Okay, like for in this particular picture, it's near the neck. Once you move it, it moves towards the fundus. So this is a mobile gallstone. It's quite different. And from the concept we developed just earlier on in my second slide, we know that these mobile gallstones are potentially the trouble ones. Right? They can then migrate out of the gallbladder, or at least they can then move to the cystic duct and block the cystic duct. So there's this more recent patient, okay, I want to describe to you. This is a 95-year-old man. Actually, he was very healthy. He was making a tour vacation every year, very happy, but he knew he has gallstone for 10 years. Unfortunately, when he came to see me, he developed acute necrotizing pancreatitis. Okay, this you can see. The whole pancreas is necrotic. Hardly see any more pancreas left due to the gallstone migrating into the bile duct and causing pancreatic obstruction. And he developed a pseudoaneurysm that bled. So because of the bleeding, he had to go to ICU. He had hypotension, and now, although he's subsided, he's recovered from the pancreatitis, he's no longer the same person. He has developed some multi-infarct dementia. He's bed-bound now because it's a prolonged ICU stay, and his life is no longer the same. Although he's alive, but his life is no longer the same. Therefore, I subject to you, maybe perhaps we have to think about this slogan again. Don't trouble unless trouble. Maybe it may not be true. We may have to think about better remove trouble before it troubles you. Okay? Yeah, better remove the trouble before it troubles you. So, if we remove trouble, how do we remove it? Currently, there are two main methods: surgical technique by cholecystectomy, okay, and the medical technique, okay, to try to dissolve the stone or to blast the stone. I think my good friend Dr. Rinaldi already mentioned about all the points about aerosol. Okay, basically it's meant to try to over time dissolve the gallstone. Okay, and there has been publications showing that there are a lot of effects, a lot of beneficial effects using aerosol, including anti-inflammatory effect, as he mentioned just now, protecting the hepatocytes, increasing the production, so thereby diluting it and increasing the dissolution ability. But as the paper suggests, okay, the paper says the story not yet completed. Maybe truly there's a bit more to the story. Okay, and subsequently, you see in this particular paper is a large population study where you compare patients who underwent aerosol versus those who did not. Okay, and there was a set of criteria and so on and so forth. Okay, subsequently they published that the overall response rate is only 47.2%. So not so satisfying for treating a gallstone. In addition, majority of patients selected were asymptomatic or mildly symptomatic stones. So maybe this paper again selected patients who were having cholesterol stones rather than the pigment stones that we see in our patients. And then they excluded a lot of patients who had jaundice, but these are the group of patients that we want to treat. These are precisely the patients we want to treat. In most of the patients, for such patients, we would have taken the gallbladder out already. And finally, when they analyzed the dropout, they found patients with acute cholecystitis and acute pancreatitis. This is exactly the picture that we want to prevent. And yet, by giving aerosol, the patients still suffer from this. So I subject to you, probably maybe we should think twice about just using aerosol to treat gallstones. So in that sense, what should we do? Being a surgeon, I tell you, probably surgery lah. Huh? Or you don't need to treat again. Once you do a surgery, take out the gallbladder, it's treated for the rest of the life. And then, in recent years, we have developed new techniques and that will help improve acceptance of our patient towards surgery. For example, in the past, in cholecystectomy, we had to use a big scar to leave a lot of wound complication, a lot of pain. In recent years, about 15, 20 years, we started doing the 4-hole technique, the laparoscopic cholecystectomy. It will definitely give less pain. It uses only puncture holes and less wound complications. But more recently, surgeons have been single incision laparoscopic surgery, which is only one hole, certainly less pain, and it can be done in a day surgery process. So all 3 holes is gone. Everything can be hidden in the umbilicus. It becomes like a scarless surgery. And I always tell my resident in the past, if we have been given one scar, don't create more, right? Just use the scar. The God gave us one scar, just use that scar, don't create more. And I went on to do a randomized control trial, which was published on the World Journal of Surgery, okay, in 2015. And in that study, I found that in patients who had a single incision, of course, they have less pain. Also, they have slightly earlier return to function compared to the 4-hole technique. Okay, this is a randomized control trial. And is it safe? Is this technique safe? Okay, subsequently I went on to publish another paper in surgical endoscopy on my first 500 series. There's no bowel duct injury. Indeed, it's a safe procedure. Okay, they can help our patients to have less pain, earlier return to activity. And how about time loss? If you pop in aerosol, you can eat for a long time, there's no downtime. But I have also, in earlier period of my time, I have also published a paper that we can actually do cholecystectomy as a day surgery. So there's minimal downtime. So with that in mind, does it mean that we should remove all stones? Do we remove all? Since cholecystectomy is so simple, little downtime, now no scars some more, should we remove all potentially troublesome stones? There are some patients that I will not touch. Who are these patients? They are the patients with high anesthetic risk. For example, patients with recent myocardial infarct, patients who had recent cardiac stents, who are on drug-eluting stents, who are on, therefore, double antiplatelet, and patients with poor ejection fraction. So I think there are recent papers to suggest that if patients are on aspirin alone, post-stenting, it's better to keep the patient on aspirin and go on with the cholecystectomy, laparoscopically. But when the patient is on dual antiplatelet, for example, for early phases of patients who have drug-eluting stent for the cardiac PCI, then those patients perhaps better to wait 6 months. So after 6 months, the current recommendation is that patients who are on drug-eluting stents on double antiplatelet, they should be on it for 6 months. After 6 months, they can drop the Plavix, stay on aspirin, and that is the time that we can proceed on with the cholecystectomy. But of course, there's a new horizon that we can think about. In recent publication, there are people who have been venturing into this technique, which can be done by my good friend, Dr. Rinaldi, For example, by EUS, they can pass in a needle and then deploy a stent between the gallbladder and the duodenum. That means they drain the gallbladder through the duodenum using EUS. The first step is to deploy a stent. When the stent matures, then we can then through this stent drag out the stone. But of course, this is a very early experience. We do not know the long-term outcome, whether this will induce changes like give rise to a higher risk of gallbladder cancer or other problem. But this is quite something very new and very interesting. And perhaps with this technique, we can avoid general surgery, general anesthesia for our patients with gallstones. We can therefore use this technique in the future to remove gallstones without general anesthesia and therefore reduce the cardiac risk. So I think in just to summarize the flow chart, since the topic is on our daily practice, what a strategy flow chart that I would like to propose. When we diagnose gallstone, number one, we see whether they are adherent stones. That means if you move the patient and you repeat the ultrasound, the stones don't move. Generally, I think we should leave them alone. But of course, you give them advice. In the event that symptoms occur, they should come back to see us. If the patient has complications already, then we have to treat the complications. For example, ERCP for bile duct stones, or for pancreatitis, we have to rest the pancreas, and so on and so forth. And then later on, among all the patients with gallstone, how about those who have got relatively minimal symptoms but are mobile, or they already show signs in the gallbladder wall thickening, which suggests mobile stones. These patients, and plus these patients, will eventually need some kind of treatment. So if they are fit for surgery, go ahead with cholecystectomy. You can use the traditional, you can use the 4-port, and the best of all, you can use a single-port surgery to optimize the outcome. But if the patient were unfit for surgery, then we may have to consider either delaying it, like in patients who had recent AMI, delay it and then subsequently go for cholecystectomy, and perhaps then entertain the other modalities to help the patient prevent them from getting into trouble from their gallstone disease. So, ladies and gentlemen, Mr. Chairman, I want to conclude my talk on this topic. So, decision to treat gallstones should be based on, number one, if there's already patient subjective symptom, or there's complication from gallstones, or imaging signs that there's already chronic cholecystitis, or they are mobile gallstones. And this treatment decision is based on the fact that now we have improved surgical technique and anesthetic safety. This helps to reduce the pain, the scar, and downtime the patient will experience, and therefore should allow patient to accept treatment for gallstones easily. And finally, there's now some new roles regards to non-surgical options, which perhaps will take a few more years to explore regards to safety and long-term efficacy. And summary, and last of all, I want to just point out that laparoscopic colectomy should be done because now it is a safe procedure, but it should be done in safe hands, that means experienced surgeon, and also in safe patients. With that, I thank you very much.